Welcome Dr. Senthil Kumar.
Thank you,
He is
sir.
MBBS, MD, DNB Physiology and MSc Yoga Therapy. He is Associate Professor in Department of Physiology, AIMS Madurai, Tamil Nadu. He is Senior Consultant at Physical Medicine Rehabilitation. He is expert in musculoskeletal rehabilitation and sports medicine. He has special interest in exercise prescription, functional training and healthy aging. And his passion is about promoting movement for better life. Hope this will be excellent presentation
Yes.
from sir. You can start your presentation. You can share your screen.
Yes. Thank you, sir. Thank you. With the permission from the chair, let me start the discussion today. As the sir has told, thank you for the nice introduction. I am Dr. Sindhil Kumar S. So today we will be discussing on the power of movement. The healthy aging starts here. How I have designed this, we can discuss many things which are theoretical, but I want to be more practical. Even if it is very less, we want to take this message and start doing it from tomorrow morning, at least 1 or 2 points. I have designed my discussion based on that. Okay. So before starting, my entire talk is based on this guideline. The guideline which is given by WHO and the ACSM, that is American College of Sports Medicine. So the physical activity guidelines for the adults. But since we are discussing with the older adults, is there any change in this guideline is going to be? I checked everywhere. They told the same guidelines which is given for adults is also applicable for older adults also. So what is this guideline? This forms the basis for our entire SKS prescription or physical activity, what you are going to assess in the old age. So 150 to 300 minutes per week of moderate intensity aerobic activity has to be there, or 75 to 150 minutes per week of vigorous intensity aerobic activity has to be there. Not only the aerobic activity, but there has to be muscle strengthening activity at least 2 days per week. So this is the guideline which is given by American College of Sports Medicine, which forms the basis for the entire exercise prescription or the guidelines which you are going to follow. The next one. How I have designed, I have already told. Here in this discussion, we will be taking mainly on preferably an healthy older adult rather than with the diseased population. So let us go with the healthy older adult. What is the question that is asked? The guidelines is given. So how many of our older adults is following this guideline? In between age 65 to 74, only 16% of the people are following in this guideline. And if it goes above 85, not even 7% are following the guideline. So this is a point to be noted. They are way behind the recommended guidelines. So what we can do for that? So let us have to genuinely think how many of us are currently asking the patients about their physical activity when you are discussing with them, if they are coming for various ailments which are going on. So we are very much concentrated on getting knowledge about their ailments and trying to cure them and getting back to the society. But have we are ever asking about the physical activity level, what they are doing? The current guidelines ACSM is giving for older adults like heart rate, BP, temperature, and pulse rate can we include physical activity level monitoring as one of the vital signs. Why they have considered this? Depending on the discussion which went on, they are telling that physical activity is an important measurement which can tell about their future health. What is going to be their disability? What is going to be their mortality? That will be determine their physical activity. So physical activity measurement is now considered as one of the important vital signs that has to be measured. Okay, now is age is an enemy? Older age, automatically they will become less functional. Is it so? No. Age isn't the enemy, but deconditioning is. Let us see, look at these two people. Both of them of the same age. This is not just an age-related image, but which we can see in our day-to-day life. When you're sitting in a park and looking at two people, same age. One person is frail and not able to do his own activities. The other person is brisk and able to walk. So what is going to be the major difference? Both of them are same age, meaning the chronological age is same. but their physical functioning age is different. So age is not going to be the enemy for us. So let us look at what is the aging curve. Before going into the aging curve, who is an older adult? Typically, all the definition says more than 65 years is older adults. For all the research purposes, I have also used more than 65. But what ACSM tells us, more than 50 years with the clinically significant conditions affecting movement, physical function, or fitness can be considered as old age. The second part, please consider the second part. This even above 50 is older adults if the physical function is less. That is the definition given by ACS. Now this is the age curve. What is this curve? Let us go with one by one. The y-axis is the functional capacity and the x-axis is the time. So when a person moves from the childhood, which is very close to the y-axis, and goes to the adult life and goes to old age. So what happens to the functional capacity is the curve. This is called as age curve. So the lowermost curve is given by the life curve of reduced functional capacity, and the upper curve is given by life curve of highest functional capacity. So what does this curve tells us? This curve tells us this black thick line is the disability threshold. If the person is physically active, even at old age, he is above the disability threshold. So what we can take a message is that age is just a number. If we are able to maintain the physical function properly, we will be above the disability threshold. We will not be requiring any support. So that is the important message. The QR code which I have given is the article for, I think it is prepared by IMAS and INCA. They have prepared this document for WHO. So you can scan and store it. I can also share it, the PDF with the group after the discussion. So this is an important take-home message. One single curve which you have to remember. If you are physically active and if you are able to maintain our physical activity level, we can be above the disability threshold irrespective of what age we are. So that's what age curve tells us. Now, I'm not telling age and we can live like whatever we are doing in the middle age, the same thing we can do in old age also. No, I'm not telling that. Yes, there will be physiological decline. We are not refuting that. These are few physiological decline that will happen in older age. Decrease in maximal heart rate, maximum cardiac output will come down, even resting BP will be rising, systolic blood pressure will be increasing, residual volume, the lung capacity will get decreased, vital capacity will come, our flexibility will be down, bone mass will be down, fat-free mass is down, muscle mass that is, and the glucose tolerance will be reduced. Yes, there will be physiological changes that will be happening in older adults. Out of this, I want you to bring the notice of the four major changes: VO2 max, muscle strength, reaction time, and recovery time. These are the four things that we have to consider when you are assessing the physical activity of the older adults and if you are moving to the next level for exercise prescription. All the others are secondary. These four things has to be considered because there are many physiological functions which will be keep on changing and we cannot monitor all the functions. We should select out of all the physiological parameters which parameters to measure so that we can keep a watch on the older adults. So these are the four physiological parameters. So health and the functional status, not the chronological age, should determine the treatment intensity and the goals. So this we have discussed. So what we are going to do from next. Okay. So whenever we see an older adult, we are noting down what is the age. That is just a chronological age. So here afterwards, what we can do, we have to ask what is their physical function also. Okay. Is it enough what is their physical function just by asking? Do we have a specific way of assessing their physical function or we can have a questionnaire? Yes. In the subsequent slides, we will be discussing that also. I will be giving you the tools which you all most of you will be knowing, but we will be sharing it. Okay. From decline to the consequence. This is my section 2. We have heard about sarcopenia and frailty. So I want to bring these two words, two jargons into this talk and we'll have a discussion on that. So what is sarcopenia? This is the word coined by Irving Rosenberg. It is just a recent term which started in 1988. Sarco is the muscle and penia is a decrease. So it initially started with a decrease in muscle mass, sarcopenia. But later, EWGSOP, European Working Group on Sarcopenia in Older People. What they have told? No, it is not just the mass. Mass may remain same, but function will start reduce. So the sarcopenia definition is now changing from loss from muscle mass and it is moving from loss to the muscle function. Sarcopenia now is about loss in muscle function. Now it is a disease. They have given the in 2016 ICD-10 CM code. Why I am talking about disease code and all? If it is a disease, it will come under reimbursement. Any insurance. Sarcopenia previously was just a term telling about people having less muscle mass. Just you are writing it and you are going on. But now it is a categorized disease for which you can give treatment. So this is a really important change which has happened in 2016. So screened via the performance. Now, if you have to measure muscle mass, most of the time we'll be going with taping the measurement and doing the circumference. Otherwise, we have to even go for DEXA, which is a costly one. Now, since the definition has changed from muscle mass to the function, we don't have to measure the muscle mass now. We have to measure the muscle function. Now it comes under EC purview. So most of the physiotherapists and even physiologists, what will is easy for us to measure. We'll be doing it daily. Grip strength, hand grip dynamometer, lower body strength. I will be doing for how much height he will be jumping for athletes. But older adults, it's slightly different. And we will go for the muscle power and even gait speed. We'll coming back to this gait speed. Please remember this. Gait speed will be very, very important in older adults. So we don't require imaging or muscle measurement. Okay. We can just measure the muscle function, which is now comes into our forte. Very, very easy to measure. So before going to the measurement, it is an easy questionnaire. Is there a sarcopenia? Yes, A, R, C, F. The 5 questions, 2 minutes. They can answer. It is we are not going to ask. Even the patients who are sitting and waiting for us in the OPD, we can give a small questionnaire. I have given a collection of questionnaire, SARC F questionnaire if the age is more than 65. If for most of the patients, I will be trying to give PAR-Q questionnaire, physical activity readiness questionnaire. Most of you are aware of it, but let us have a discussion on that also. So what is this SARC-F questionnaire? The strength is difficulty in carrying 10 lb. 10 lb is American. It is just around 4.5 kg. If difficulty, no difficulty is 0, some is 1, a lot is 2. The score is given. Similarly, for assistance in walking, or rise from the chair, or climb in the chairs, or is there any falls in the past year? They have to just give a score. If the score is more than 4, it suggests sarcopenia. They can be sitting in the outside and they are coming inside with this answer and their score is 5 or 6. Then you have, okay, now for this person, I have to measure the muscle function. If it is less than 4, no, you can go carry on with our routine test. This is what I was talking. Practically applicable without any extra time because we are very, very bound with time. We will be spending less time in our OPDs. So what we can do, what is possible to do. Okay. Now there is a confusion. Most of the people are interchangeably using sarcopenia and frailty. Even in our community or in physiology, they were not too much aware. So I want to bring what is the difference between sarcopenia and frailty. Okay. A specific muscle condition, okay, decrease in function. Okay. But in frailty, it is a broader clinical syndrome, weight loss, slowness, weakness, sedentariness, and fatigue. So the frailty includes sarcopenia, but it is even more than that. Okay. Frailty predicts poor outcomes, hospitalization, disability, and death independent of any single diagnosis. Old age people may have hypertension, they may have osteoarthritis or asthma, respiratory problems, or cardiovascular disease. But the frailty alone can predict, okay, their mortality and morbidity rate. This is the important take-home message because we are not at all measuring what is their physical function. We are more concentrated on their heart. We are more concentrated on their muscles and bones, joints, bone joints at older age, but we are not concentrating on their physical function. Okay, frailty is a pattern. What are the patterns? Is there any fatigue? Is there any resistance while they are trying to climb the stairs? Or aerobic, if they are walking from one block to one street to the next street, if they are feeling difficulty in breathing, is there illness which will not go? There is a recovery. Okay, illness more than for 5 days and loss of weight more than 5%. This also will be giving mark from 0 to 1 to 2 and say if it is 0, none of they have told everything, I don't have anything, then it will be 0. If they answered everything is there, it will be 5. So 1 to 2 is considered as pre-frail. So what we can do is use SARCF question, just 5 questions for every patient more than 65. We can start that. Okay. If it is more than 4, then we can move for muscle function. We cannot go for every old adult, we start muscle function and start testing. It's not possible. Okay. Now we are moving to the next functional assessment. As I have told, yes, we have now screen. Now how to assess the risk, how to measure it. Okay. So previously they were doing exercise stress testing. I have also told about cardiopulmonary exercise testing. We have had discussion previously. But can we do exercise stress testing for an older adult? It is a costly phenomenon. First, the instrument is costly. Second, you need a full setup. BLS, ACLS trained has to be there. All the faculties has to be trained in that. Then you should have a continuous monitoring of ECG, continuous monitoring of VO2, oxygen, everything. But now uh, it has moved from exercise stress testing to the physical performance testing. In older adults, they have told physical performance testing is as equal that of exercise stress testing, determining their ability or the physical function. So they told that if you are going to prescribe an exercise, let us proceed with physical performance testing, and you don't have to do a exercise stress test unless it is recommended or unless it is indicated for any particular disease. We don't have to do it. That's what the recommendation given by American College of Sports Medicine. Now, what test? There is hundreds and hundreds and hundreds of tests. But these are the 7 tests which ACSM recommends. Most of my recommendations in this talk is from American College of Sports Medicine. They have good book guidelines for exercise testing and prescription. And American College of Sports Medicine is an appellate authority for most of the exercise testing and prescription, and even WHO follows that. Even the Fit India, the organization which is giving the physical function for the entire India, is also following ACSM guidelines only. So I have taken the points from there. So there are so many tests. I think most of you have heard about this also. But out of this, I will be discussing only the 3: SBBP, gait speed, and time to up and go test. Okay. So why we have selected these 3? Important is these 3 are easy to do. Even in OPD, we can do. That's the most important point. Even in OPD, we can do this. And what they have told is, by doing this, you can predict the disability and the mortality. These 3 tests have the strongest predictive value. So I have selected these 3. So what this battery, this SBB battery, short physical performance battery of test, what is going to tell? First, it has to test the balance. Next is the gait speed and the chair stand. Okay, we will not go into how to do it. Just we can note it down, but I will be giving the importance of it. 3 stances, 10 seconds each, side by side, semi-tandem. It's for the balance test. Gait speed, walk of 4 meter at a usual space, and you will just time it. 4 meter and how much time. And chair stands. Without support of the armrest, you have to ask older people to sit and stand 5 times with the arms crossed. How much time it will take? So we'll be scoring for each 0 to 4 and sum to a total score of 0 to 12. Nothing, no equipment needed. Just an armless chair and just a 4 meter in a hallway is enough, and a time watch. Time watch, all of us will have in our mobile phone. So that should be enough. Even a 0.5 point change is a meaningful change, and 1 point is a substantial change. So what we can do, if you measure this, we ask the subject to measure it today, and after 1 month when you are reviewing, we can again use this to see how much change our intervention has been given. Or even we can tell that they have not deteriorated. They are at least maintaining. At older adults, that is more important. They should not deteriorate. So this is an one test. The second one is even more easy. Gait speed. Mark a 4 meter walkway. They have to just walk just that. It can be either 4 meter. In 4 meter, there are 2 gait speeds. In 4 meter, you will be measuring the time. In 6 meters, you will be measuring the speed, how speed they are walking. Well, let's go with the 6 meter gait speed. 6 meters distance has to be there. It need not be even in a straight line. It can be they can go front and back also. So you ask them to walk, how fast they can walk, and you will be recording it. So they will be walking at 1 meter per second. That much speed they should be walking. Okay. If they are not able to walk at prescribed speed or their speed is reduced. That is the most important diagnosis or the most important recording that you can make. As usual, when a subject is coming, we'll be recording their pulse rate, their blood pressure, temperature. Similarly, you will also write the gait speed is 0.8 meters per second, so on. This is the important vital sign. I want to bring to your notice, at 75%, at 75 years, 10-year survival ranges from 19 to 87% and 35 to 91% across grade speeds. Okay, your gait speed can predict the 10-year survival range. This is an important take-home message. The cutoff point is less than 1 meter per second is lower function. You just have to measure the speed, gait speed. Next comes the timed up and go. Okay, this is slightly a different test where the subject will be sitting, ask them to stand, walk for 3 meters, turn, return and sit. This is like a combination of all. Sit to stand, then the balance when they are turning and walking at what speed they are going. Okay, so these are the 3 tests which you can do. Why we have selected these 3 tests, I have told. If there is a quick OPD visit, ask them to do only gait speed, nothing else. Even out of these 3, do only the gait speed. If you have slightly more, ask them to use timed up and go test. If you have more time, we can go for full assessment, take the short physical performance battery of test. If you have even more time, then senior fitness test is there. That will be 7 tests. Okay, so depending upon our availability and in which OPD we are sitting, we can filter which physical performances will be. At least one we should be doing. That will be our consensus today. Okay, now, yes, we are measuring it is less. Can I start just like that? That is the question. Especially these are older adults. Okay, is it our main question will be most of the people are when starting the exercise they may feel bad and they will have a cardiovascular risk and they will have a respiratory risk. Simply we have started an exercise. Will they be able to tolerate? What will happen if there is some side effect? These things will be going on mind. So let us discuss for this what we can, how we can come out of this and confidently prescribe exercise for them. So what is required for that? What is required is a pre-screening. To whom, when to give exercise, at what capacity to give exercise, and what type of exercise has to be given, at what intensity, at what duration that has to be given. Okay. So ACSM is also again coming in hand. How to do the screening. Okay. Why this is required? When we routinely do an ECG test, we take an ECG. What happens in older adult is since there is left ventricular hypertrophy in most of the individuals, the ECG, the false positives will be more. So routine testings will give false positive and they'll be keep on visiting the medical. So let us go for the different screening. Small adjustments and safer testing has to be there. Whenever we start physical activity to older adults, we start at very light, less than 3 minutes and small increments. We will come back to this metabolic equivalence. That will be difficult to measure. That's what most of us, even I, when I start giving prescription walk, how much is that med? If they start walking, how much is the med? I have to keep on calculating it. Let us have a different way of prescribing the exercise rather than calculating the meds. Let's come back to that. Okay. Cycle ergometer preferred. Handrail support is required. Even our heart rate is not correct for older adults. They will be taking most of the people will be taking beta blockers. If they are taking beta blockers, their heart rate will be reduced. Even if they are doing the exercise, their heart rate response to the exercise will not be appropriate because they are taking beta blockers. Even some of the calcium channel blockers will alter your heart rate response to the exercise. So we have to be very, very careful. Okay, even in normally even in aging, the heart rate response that usual the 22 to minus age the HR max equation will not work. Okay, so ACSM pre-participation screening has 4 questions. Are they regularly exercising? Older adults, we have few nowadays people have started walking daily. Older people, they have a separate home, they will have a separate routine because they have more times. Second questions is if they have any metabolic diseases, cardiovascular, respiratory, renal, any diseases, or they have any signs, difficulty in breathing, or they have chest pain while working, or any edema or palpitations, known murmur. Then fourth question is at what type of exercise intensity they want to do. Older adults, we usually don't go for vigorous. It will be from light to moderate. They want to do a normal activity. So most of the recommendation for me was Sir, I want to go to this temple. The temple is in a mountain. Can I climb? Practically, that's what I faced. Are they fit enough to climb? That comes under even vigorous. So we think older adults won't go for vigorous, but their requirement may be vigorous. So we have to be careful at what is the desired exercise intensity. So these are the four questions. Four questions. How to utilize that? Let us start with. If an older adult has come, just four questions. Participates in regular physical activity, yes or no? Okay. Regular physical activity, what does it mean? Daily 30 minutes, they should be doing a moderate activity. That is called as regular physical activity. Okay. If they say no, then we ask, does they have any known diseases, cardiovascular disease? Or do they have any symptoms? Let us go with the first box. No CV, no metabolic disease, no signs. Yeah, very healthy. Second, known disease like diabetes, but there is no symptom. They are asymptomatic. Third person is they are symptomatic, whether they have disease or not disease, because they would not have been diagnosed. So for these three people, what we are going to do? Medical clearance is not necessary if they don't have disease and don't have symptom. If they have a disease, medical clearance is recommended for both diseased and symptomatic. Okay. For all, we will always start with light to moderate intensity exercise. For no symptom, no disease, we can even progress to vigorous. This is what I was telling. Those people who want to go to temple in the mountains, if they don't have the disease, if they don't have the symptoms, yes, we can ask them to progress to vigorous physical activity also. But it is gradual. They cannot do within a month. It will take some 3 to 4 months to accommodate, and we have to progress. That we'll see later. But they can do. Yes, they can do. If they have CV diseases or symptomatic, they can again start with light to moderate after the medical clearance. They have to do a medical testing and see whether they are able to do light to moderate, and then we will progress. Now, if they are actually doing physical activity, how to go with this? Again, the same questions. There are three people. No disease, no symptom. Disease is there, but asymptomatic. But symptoms are there. But they are doing the exercise. Here, what we have to do. This point I want to say. If they are doing the exercise, few people will do the exercise even though they are having the symptom, thinking that that will help them. Please ask them to discontinue the exercise if they are symptomatic. Okay. No disease, no symptom, doing the physical activity, nothing. They can proceed. They can do whatever they are doing. If they have the disease but asymptomatic, medical clearance for moderate intensity not necessary. But if they want to do vigorous exercise, then the medical clearance will be required. Okay. So continue to do the same thing will go. But for discontinue, please note, if they are even doing the exercise and saying, yes, sir, routinely I am doing, but they're asymptomatic, stop. Do the medical test, then we can proceed. I think now ACSM has given a clear guidelines. So whatever we are asking the physical activity level when they are sitting, noting it down, how much exercise we can prescribe, we have this guideline, just this flow chart. Four questions. We can be very clear whether to send this patient for medical clearance or we can start writing the vigorous or light to moderate to vigorous activity. Okay. I think this would have cleared most of the doubts which we are having in our mind. What to do. Okay. Even before that, there is a criteria. These people already, whether to start or not, they are not doing it, but they don't have any symptoms. This is a self-assessment questionnaire, PARQ, physical activity readiness questionnaire. Just a 7-point questionnaire. Okay, this QR code you will take to the ePAR-X. This is a website which is dedicated for this. Okay, 7 questions will be asked. If they answer no for all the 7 questions, then they can start doing whatever type of exercise they want to do. If they are answering even yes for any one of the questions, then the plus part will start. Depending upon their yes for what question they have answered, then the questionnaire will elaborate. Then if you answer for that, then they can decide whether they will go for exercise or not. I want to separate. PARQ is self. The patient will fill for themselves and they will determine whether they will go for physical activity or not. But ACSM pre-participation screening is for us exercise professionals, whether to prescribe the exercise or not, whether we require medical clearance before prescribing an exercise. That is for us. So most of us will be using ACSM only. Okay. The medical clearance is needed if the disease is present or symptoms are present, or the patient is not currently active and wants to do a vigorous activity. Otherwise, proceed. This is just one sentence, simple rule. Okay. So whatever we have decided, we are going to assess more than 65. Use SARCF, sarcopenia questionnaire more than 65. If it is the score is more than 4, we will go for muscle function testing. What is muscle function? There are many tests. We will be going with gait speed, or time to up and go test, or SBBP, short physical performance battery of test. If we have more time, then we can do more. But these are the three basics which you can do. Okay. Now we have assessed how to convert this into an action movement. That's what the topic is about. Healthy aging. We have to ask them to move, but we can't simply ask just get up and walk. Okay, so we should be having a prescription for that, like and how a medicine is prescribed. Whenever we write a medicine, we will say what medicine, when to take, how much to take, how to take, before and after, what are the precautions, how long you have to take. Similarly, exercise is also a very, very important drug for which we require these 6 components. What are the 6 components? Frequency, that is how often you have to do. Intensity, how hard you have to do. Time, how long you have to do. Type, aerobic, resistance, or flexibility. Volume is just a combination of intensity and the time. Okay. Frequency, intensity, and time combined is volume. Progression, yes, this is important. Why this is important? Whenever a subject comes, we will ask them to do some exercise. Then we have to review whether they are going down or up, and we have to modify the drug, which we already do. Similar, we have to modify our exercise prescription also. This will hardly take 5 minutes with the patient, but we are going to give a 10-year survival rate can be increased just by giving an exercise prescription. Okay, so let us see how it is done. This is recommended fit VP for older adults. So when you are going for aerobic, frequency is 5 days, resistance at least 2 days, flexibility at least 2 days. Here I want to slightly differ. Flexibility we can combine as a cool down or a warm up on most of the days, which I will be coming back. This is recommended, but we can do in most of the days. Sometimes we can combine it with balance and coordination also, so that we can do it most of the days. Intensity, RPE, this is rate perceived exertion, rate of perceived exertion. There is a scale called BORG, Borg scale. It is from 0 to 10. In that, we have to go for moderate intensity exercise. Then, if they are able to tolerate, we will go for vigorous, that is 5 plus. Similarly, for resistant exercise, we will go for 40 to 50% of RM, 1 repetition maximum. Again, this 1 repetition maximum, I had a discussion in a previous college. Can we ask older adult to lift as maximum as possible in chest press or a dumbbell? Is it not dangerous? Yes, it is dangerous. Most of the people, we don't know what is their background also, so we should not ask them to do a 1 rep maximum unless otherwise they are very fit older adult. Most of the people, we will be even afraid to ask them to do 1 repetition maximum. There is an alternative for that. What is the alternative? Ask them to take a lesser weight, some 2 to 5 kg dumbbell weight, and ask them to do 15 reps. If they are comfortably doing, okay, that is their weight is very, very less, then you have to go for a higher weight. What is the suitable weight that they can do is for which they have to do resistant exercise rather than following this 40 to 50% or 60 to 80%. There is an alternative. How much weight they have to lift. When they are doing 15 rep, the last 2 reps should be difficult for the given weight. That is the suitable weight in which they have to do the resistant exercise. I think this should help for most of the resistant exercises. Then flexibility, point of tightness, not point of pain. Okay, very, very important. Time, how much is the time? Aerobic exercise, as we have discussed, what is the guideline? Accumulated time of 150 minutes. What is the meaning of accumulated time? Again, practical feasibility. Today, I had a practical class and we had exam from morning to 8 to 5. Evening, I am coming and doing half an hour. So only that half an hour is considered as aerobic. So what happened to morning 8 to 5 in which I was doing physical activity, running here and there, moving? That is also considered as physical activity. Yes, that has to be considered. But that is two or separate. Okay. Breaking the sedentary life is equally important as doing a physical activity. Okay, both will give cumulative effect in the physical well-being. When you are sitting for 8 hours and doing a 30 minutes exercise at the end, okay, compared to the second person as a teacher who is walking for that 8 hours intermittently and doing the 30 minutes exercise, both are not equal. The person who has broken their sedentary habit will be more healthy. Okay, that is one point. Now, what is this accumulated? Okay, I have slightly deviated. What is this accumulated? The 30 minutes you have to don't do continuously. What ACSM has told, you do even 2 minutes of aerobic exercise of moderate intensity, and 2 minutes you can break and find that 30 minutes over a day. That is called as accumulated. So you can have 2 minutes of moderate intensity exercise at the morning, during the tea time, during afternoon, in the evening, then you will come and do 15 minutes of moderate intensity. That accumulated 30 minutes is enough. That's how you can achieve this 115 minutes per week, up to 300 minutes per week. Okay, that is called as accumulated. Coming to the resistance, 1 to 3 steps, 3 sets of 18 to 15 repetitions. Again, this exercise prescription will keep on going. I'm very much interested in this exercise prescription. Okay. Then flexibility, important point here. Again, most of the people will not do this. They will flex and then go back, and then will flex the other leg and then come back. They will not even hold for 2 seconds. You have to hold for 30 to 60 seconds to have the flexibility effect. Hold for 30 to 60 seconds. That's why I told it's point of tightness, not point of pain. If the pain starts, then slightly come back. Okay. So I think I have given a somewhat overall idea. If we keep on, there are so many points to be there, but please remember frequency, intensity, time, type. This fit is very, very important. Okay, volume is accumulated one, and how to progress depending upon how they are responding. How frequent you have to visit them back to progress also. That is also very, very important. The yardstick is we can go with the 10% increase. That is the progression. Okay. Rate of perceived exertion, most of you have been using in your research or in your day-to-day practice also. This scale rating is given by the patient or the subject, old adult. We will ask them to do something and say that 0 is nothing and 10 is extremely hard. What are you feeling now? They will give the score of 3 to 4. Then 3 to 4 will be the moderate intensity. This is given by the patient, not by us. This also I found difficult. Most of the older people are finding it difficult to say this is the range or what is the number to tell. They are finding it difficult, especially village people when I are discussing with them. So what next? Talk test. Please go back and read what is the talk test. We will have a discussion on that. I have tell it in full, small snippets. When they are doing the exercise, routinely they will go for a walk. They'll be talking and walking. That is below the threshold. Actually, that is light intensity walking. So most of the people who are going for a walking is not even reaching the moderate intensity. They are doing a light intensity exercise and they're expecting the result. To health benefit to happen, they should go for at threshold, meaning they should be able to short phrases only. When they are walking, they should be able to speak in very, very short phrases. Otherwise, they should not be able to have a gossip. They should not be able to sing. They should not be able to talk. They will not be able to do that. Then only they are reaching the moderate intensity of exercise. If they cannot talk at all, then it is going to the borderline of vigorous activity. So this talk test is actually a recognized test, which is even used by American Council on Exercise. Okay, my medical exercise specialization certificate is from American Council of Exercise. There they have given this talk test. ACSM is predominantly concentrating on rate of perceived exertion, but practically when I am prescribing an exercise, I am finding it very difficult to tell the actual number. Better than that, I will be giving this type of thing where I can tell what is the light intensity, what is the moderate intensity. People are able to connect with it. So they can say, sir, when I am walking, I am able to speak only small sentences, not even able to complete the full sentence. Then you are at moderate intensity exercise. So this I found will be easier to prescribe the exercise. Next, while you are prescribing exercise, you have to change. Okay, not do the same exercise again and again. Walking I will do daily, then it will lead to knee problem also, then it will lead to back pain also. So walking is good, but you have a multimodal exercise. You have to combine flexibility, you have to combine resistance. Even aerobic exercise, you have to give variability. Okay, multimodal is for flexibility, balance, resistance, aerobic, Even HIIT, high intensity interval training, is recommended for older adults. Okay, we'll come to the discussion for that also. So how this looks, how will you prescribe? Monday, Wednesday, and Friday, alternate days, we are giving 30 minutes brisk walking. Tuesday and Thursday, in between, we can give resistant exercise so it can recover. I have told one of the most important point that differs from adult to older adults is the recovery period. Adults will go for gym daily. They will do for one group of muscles and they can recover. But older adults, the same time, they may require more time to recover. That is the problem. So give alternate days. Give one day complete free. Tuesday and Thursday resistance exercise and daily 5 to 10 minutes of stretching and balance practice, as I have told earlier. This is a simple exercise prescription which you can start telling to your patients from tomorrow. Okay. Uh, we are slightly going away. I will be touching on importance of it, and they will be closing the session for today. Okay, just 5 to 10 more minutes. Bear with me. Power. What is this power? We have been talking about muscle mass. Now, sarcopenia has moved from just measuring the muscle mass to muscle function. Now, older age, what they are telling, power is lost even before the strength is lost. So, muscle power is different from muscle endurance and muscle strength. The muscle power, how much power they are able to generate with that muscle is different, and that is lost earlier than even the strength. This is an important message because when you are giving a resistant exercise, what type of resistant exercise will determine whether you are working for power or working for endurance or working for strength of the muscle. The repetition and how much weight you are going to take and how much repetitions you are going to give and what is the recovery period between that resistant exercise will determine which component of the muscle you are going to address. That is very, very important. So when you are giving a resistant exercise, your prescription has to be determined by which component which you are going to touch. Okay. So traditionally, what we'll be giving is 1 to 3 sets. When you go to the gym, they'll go for 30 to 60% of one rep maximum, 6 to 10 reps continuously high velocity that will be going. But we can shift few weeks to cluster set. Only 4 repetitions or even less. Shorter recovery. Don't give only 5 to 10 seconds. Usually for 1 to 3 sets, we'll give a minimum rest of 30 seconds to 1 minute. But in cluster set, we'll give a short recovery of 5 to 10 seconds, but the repetitions will be only 4. Okay. If we do these type of tests, the power of the muscle is increased. Why we are talking about so much about power in older adults now? Okay. Because I think I have missed that point. Because the increase in power determines the 10-year functional rate or the 10-year mortality rate better than increase in muscle strength. So these are the few points which ACSM stresses. So concentrate on the muscle power for older adults also. Okay. So high intensity interval training. We will never think about this for the older adults, but ACSM says high intensity interval training will improve the cardiorespiratory fitness and more importantly, the cognitive function. Whenever you go for older adults, we will think about their cognitive decline also. But whatever the exercise we are doing, compared to resistance, aerobic is better for cognitive function. Even in aerobic, high intensity interval training is better. So we have to find how to give this high intensity interval training. We can give both body weight high intensity interval training and machine based high interval training. What they have told us, machine based high intensity interval training is better than body weight training. Okay. This graph is there and it is especially told in a research paper. You can reach 90% of heart rate maximum by doing both body weight and equipment dependent high intensity interval training. But the VO2 max achieved is equipment based. 85% of the oxygen consumption is there only in equipment based high intensity interval training. In body weight dependent high intensity interval training, the VO2 max is less. What is the scientific background for this? The cardiorespiratory fitness, the heart, how much it pumps, and respiration, how it functions, is given by the VO2 max, not only by the heart rate. So if you want to have a better cardiorespiratory fitness, go for a high intensity training with equipment. That is the Important point to be noted there. Okay, so no new equipment required. We can go with along with the simple resistance band. With that itself, we can give. How we are going to design the high intensity training matters the most. Okay, coming to the last section, the falls. We cannot close a physical activity for the older adults with sarcopenia or frailty without having a talk on the falls, because 1 in 4 individuals have a fatal injury and they will be completely bedridden with the falls. 1 in 4 falls every year. Okay, and fall related injury is 40% and fall related fracture is 66%. Okay, it's high. So how to address this falls? You can start giving a progressively balance also. As we have told, 3 days aerobic, Monday, Wednesday, Friday. In between Tuesday and Thursday are going to give resistance. But for all the 5 days, in warm up and cool down, we can include this flexibility and balance training also. That's why I told flexibility and balance training can be in all the days. Okay, tandem walking, cross walking. Okay, postural muscle has to be stressed. Okay, what are the postural muscle is our thigh front muscles and the back muscles are the postural muscles that has to be stressed and reduce the sensory output, even by asking them to close the eyes and try to walk or turn the head to one side and the walk. Even this will be very, very difficult for the older adults. Okay, and they have told tai chi, where they have written many papers that it will be very, very helpful for balance. For us as Indians, I think we have Vinyasa yoga and the yoga flow, which will be very, very useful for us to maintain the balance and flexibility and muscle strength also. So yoga is like a combination of most of the things. Okay, it will come for flexibility, it will come for balance, for muscle strength also. And if you are going to do in the yoga as a vinyasa flow, then it will come for aerobic capacity also. Surya Namaskar, there are fast Surya Namaskar, which will increase your VO to max. We have done a research on that and published a paper also. Okay, so balance, we have addressed that also. So whenever we are going to give a exercise prescription, remember it should be multidimensional, okay, and mobility based, and multitasking will improve. Each and everything will add a functional component to the older adult, which will improve their day-to-day life. Multi-component or multi-dimensional exercise is always better. Okay, every patient starts somewhere on the progression ladder. Start from there, and we have to progress slowly. Okay, when we have to progress, usually we will go with 4 weeks, but if they have any symptoms, then we'll go for every 2 weeks. That's for the progression. Okay, now we have looked at screening, how to assess, how to prescribe, and you have prescribed also. What is the major problem? We have given a very best prescription, whether they will follow it or not. That's where everything falls on the face. Okay, we have to assess whether they are in pre-contemplation, not currently considering the change, or they're in contemplation, aware that exercise helps, but they are may or may not start preparation. They know about it and they want to start. This preparation stage is the subject where you have to start prescribing the exercise. If they are in the previous to pre-contemplation, contemplation, even though you know you have to write a exercise prescription for them and you want to spend time with them, they are not ready. Whatever the exercise prescription you are going to give, they are not going to follow it. So what we have to do, try to bring them from pre-contemplation to contemplation, from contemplation to preparation stage, then you have to give the exercise prescription. So you have to talk to these people, importance of the exercise, let them realize and come to the preparation stage, then only you can start giving exercise prescription. Action is they will be actively doing it for 6 months and maintenance. That will come later. So what are the basic barriers we have faced? Lack of time, motivation, or knowledge, social isolation or lack of support, older woman, fear of injury. This is the most important point. Nobody is support. If I fall, who will take care? Okay, that fear is really, really, really important, and this is totally different from our young adults. Fear of injury and pain. This I have seen. This will be a counterproductive. Whenever we see older individuals, we will try to support them, but it becomes counterproductive. We wanted to care for the older adults, and if we give a support, too much support, what happens is that they will become even more frail. If an older individual is there and we have to leave them to do their own activities by themselves. Don't help them in doing their own activities, which day-to-day life activities. If you are going to support them in that, their physical activity is reduced, muscle mass will get reduced, their muscle strength will get reduced, and becomes a vicious cycle, which will be detrimental to the older adults. Our intention was good. We want to help the older adults, but we are counterintuitively damaging their body and pushing them to the brink. So where we have to. So whenever we want to help a older adult, let them ask, or let us be in a supportive role. Don't take an active supportive role. Don't go and do it for them. If they require, then we will give the support. We have to be in that space. Okay, I want to give a special slide for this also, because most of the people are old age home. They are giving food to their rooms. Nurse will take care. Their dresses, they have been washed and given to the rooms. So they are simply sitting from morning to the night without doing any physical activity, unless otherwise there is a prescribed physical activity session in their old age homes. That will be available only in very high five old age homes, not in the routine old age homes. There will not be no physical activity. So the people who are put in the old age with every support are actually harmful to the old people. Okay. So to the patient, ask what activity they would actually enjoy, not just what should be prescribed. The most helpful thing you can do is walk with them and not do it for them. Okay, don't go to that level. Okay, I think we have coming to the end of the session. So let us summarize what we have learned today. First one we have decided is, let us go with the SARC, SARC screening questionnaire. That is only 5. It will take only 2 seconds. Let us give it to all the people who are more than 65. Then we can measure it. Go with gait speed as a vital sign. Don't leave it. Gait speed or short physical performance battery or time to up and go. Then when to start, if they have disease, whether to go for medical screening or we can prescribe exercise. That ACSM's 4 questions that we have discussed. Then prescribe a multi-component exercise. Fit, frequency, intensity, time, type, volume, and progression. That we have to remember. Then not only the strength, but also the power. We can even give high intensity interval training also. Okay. Then comes the important point, the balance, false. So we have to remember that we have to give balanced physical activity prescription also. And what is the role of the family? We have to talk to the family, walk with them, not for them. These are the 7 take-home messages which we have been discussing in this talk. Thank you. Thank you very much for the opportunity. I think if there are any queries, I will be ready for that.
Thank
Thank you,
you,
Dr.
Dr.
Senthil. Yes, Dr. Sudhir Mishra, sir, please.
Uh, Thank you, Dr. Santhil. It's very nice presentation and very informative. And it is, I would like to thanks APP also for bringing such type of lecture in our routine presentation, which we are doing related to the pain, ultrasound, and all these things. The first time I feel we had went away from our routine lectures, and it was very nice presentation, very informative. Actually, all of us will be having our parents as old age. Even this will be helpful for us also to take care of our parents and take care of ourselves. Dr. Sanjeev, you are having some
Yes,
questions?
yes, sir. I have some specific questions to Dr. Senthil.
Yes, sir. Yes, sir.
Some
Mm.
practical question which I want to ask. We see a lot of low back pain cases and knee pain osteoarthritis cases
Yes.
who are more than 60 years of age, or who are having the body, they're overweight, or we can say. So
Yes.
whenever we prescribe exercises to them, then they say that after only 1 to 2 rounds of exercise, only 1 to 2 holding for 10 to 15 seconds exercise they're doing, that they feel a lot of dyspnea, or they feel
Mm.
they are unable to do that. So how to counter that in that situation?
Yes, sir. When in the talk I have told, they will be in a spectrum of physical function. We have to start from where they are. One of the problem is, we have a guideline of 150 moderate accessibility. When we are writing the prescription, we may have taken them to a higher level, which they are not ready to do now at present. One important point, whenever there is a physically active pain, we will not be giving any excess prescription at that point of time. We'll have to recover them and come back to normal. That is taken. I think everybody will be agreeing to that. Second,
Okay.
whenever they are going to start an exercise, we will start even with 5 minutes. Low back pain, we have worked left and right side. So whenever they have low back pain, they can't even walk. There is a problem. So what we have done is rather than walking, can they do sitting or lying down exercise, physical activity? We have even started from there till their low back pain is getting reduced. So we will be concentrating on correcting their muscle function. That is corrective exercise. We will be starting from functional exercise and correcting exercise during that time. We will not be going for the actual exercise prescription, which requires aerobic resistance and routine. Before that, they will require a treatment from low back pain is physiotherapy and excess prescription is separate. In between gap, there is something called corrective exercise and functional exercise which they have to do before they get ready for the excess prescription, sir. I think that is the link which we are missing because
So basic stretching exercises, if you want to start in that
yes,
patient, so
yes.
they are feeling dyspnea with a basic stretching also, sir. That I think that should we continue that or not?
Yes, sir, we have to address it. That's what I'm saying. That corrective exercise will address to that points. And
Uh,
body weight, the excess prescription will not be the same. I think that will be a totally for how to reduce body weight, excess prescription for cardiovascular disease. What is the excess prescription for diabetes? We will not be going for one pill fit for all. For
okay,
each
okay,
and everybody, we have a separate module for excess prescription. For example, if it is diabetes, he will go for hypoglycemic episode. We will give this 30 minutes of aerobic exercise.
okay,
So when he has to do the timing of the exercise will depend upon whether he has taken food or not, and we should have a chocolate in hand. And the person who is in hypertension, if we give a exercise, they will go for post-exercise hypotension and go for fainting, sir.
okay,
So,
okay,
so for them, we will change the exercise prescription. Similarly, for low back pain, their warm-up period and cool-down period will be entirely different, and what type of exercise we will be giving will be entirely different, sir. We will not be giving this routine aerobic. We will not be giving this walking or running or jogging for them in the beginning. Their type of
okay,
exercise which they are doing will be different, sir. We will have a, I think in ISSM, we had a talk on exercise prescription with various diseases.
okay, okay,
Yes, sir. In that, it will be slightly different, sir. Yeah.
okay, okay, okay. And okay, any other questions from any other from audience?
In chat, there is no question. Uh, I will add on to your answer, Sanjeev.
Yes,
I
sir.
what usually do, I usually start with a gentle stretching exercises because such type
Mm-hmm.
of patients they are not means all the muscles are already muscles and ligaments are stiff. So even the stretching also should be started. I feel gently, and if in a week they will progress to the normal range, then also is okay. If the we I expect ki adequate amount of stretching this patient is able to do, then gradually strengthening can be done. But what I do, I usually start with a gentle stretching only, and
So even
with
with a
short
basic
spell
stretching,
also.
also the patient feel a
That
lot of dyspnea. So, that is so. So that's the main biggest issue. So we have to modify that
Yes.
no
exercise
complete
procedure.
stretching. Don't allow a complete stretching. Does
Mm-hmm.
means just he starts feeling dyspnea as soon as he starts, he should stop.
Mm-hmm.
Gradually we can go because there is we don't have alternative to do
Mm-hmm.
to reduce the weight and to improve the function. We required this. So
Okay.
and this required a lot of motivation and lot of confidence inside the to the patient. He can perform the activity. So this takes time, but gradually they will do. And those for the obese is become slightly more difficult. And what I feel like our culture is there, na. Every time we support these people, and we are from ancient time. We are more supportive, and what people will feel, and sometime even for our parents also, we need to become slightly harsh. So that is also required because our human nature is to remain lazy. Whatever thing people means, whatever person will feel easy, he will go for that. This is the
Yes,
thing.
yes.
Yeah, that is the thing. Uh, Thank you,
So,
sir. Nice
uh,
presentation. I think
Thank-
one question I think in chat: effect of caffeine upper limit. Is the effect of caffeine upper limit? Dr. Senthil,
Yes, sir.
are you there?
Oh, yes, sir.
Uh-huh. There was one question in a chat box.
Hmm.
Uh, Effect of caffeine upper limit.
Dr. Jatin, you can just unmute yourself and you can ask the question directly.
Yes, yes. Yeah, yeah.
Effect of caffeine on exercise. So what exactly do you want to know? Dr. Jatin, you can just unmute yourself.
Sir, I want to know means upper limit of caffeine and normal young
Hmm.
on exercise or
Yes, sir.
normally asked. I want to
Yeah. Sir, I think this question
and
originates
incidentally
from,
also.
uh, I think now it has become a common practice in most of the gyms to ask them to take a caffeine-related drug before they are coming to the gym. And
Yeah,
yes,
yeah, yeah. Yes, yes, yes,
yes,
sir.
I think this question originates from there, most of the period. Sir, ideally, we will not prescribe any caffeine intake before that. It is not a prescribed form of doing an exercise in any of the ACSM or WHO criteria. Till now, even though there are many studies which has been published, till now it has not been recommended by ACSM or WHO. First point. Whether it will help in doing the exercise, the important point is what is the goal of your doing the exercise matters a lot. Caffeine is going to increase your basal metabolic rate and it will help you to do the exercise better. And if you want to reduce the weight, few of the people have used caffeine as one part of it so that they can sweat more and the loss of calories will be more by taking the caffeine. That is the background of using the caffeine for exercise. Okay, na sir? But to tell, ACSM and WHO has not required take a caffeine and then go for a walk till now. But it will be
Okay.
useful. Yes, in few studies it has been shown to be useful, sir. How much it has to be taken? For that question, it is still dicey. But one point, if your resting heart rate is going to increase by taking the caffeine, you should stop.
Okay,
That
okay,
is
okay.
that you
Okay.
should stop. Never it should increase your resting heart rate. Okay. But the dose curve is not yet been clearly defined, sir. I think I have answered the question. Okay.
Yes, sir. Yes, sir. Yes.
Yes, sir. Yeah.
Sir, whether
So,
Yes.
caffeine is helpful or means physiologically.
Low dose of caffeine is found to be important physiologically in few of the research studies, sir. Yes. And a few against is also there. That's why I told the still it is not come in book because both the studies are there. We have told caffeine is good for cardiovascular risk factors if we are taking low dose caffeine for daily. But one more study is telling no. That's why it has still yet not come in the textbooks.
Senthil, considering this question,
Yes, sir.
uh, can can we means to which type of patient we
Mm.
should promote the caffeine, or to whom those who want to reduce weight, should we prescribe them they can add in this thing,
Yeah.
or we can avoid this?
Sir, for older adults, I will prefer to avoid because their heart rate will shoot up even with light intensity exercise. So never
Yes,
ever for
yes,
older
yes,
yes,
adults. So caffeine
yes.
is for young adults. Well, that also we will not recommend, but okay, young adults and
But
those want to lose weight, we can give, sir, young adults
yeah, those who
without
want to
any other
lose
risk
weight.
factors. Yeah, yeah.
Yes, yes, yes. I don't feel by adding anything. This is my personal thought. By we should not add anything to improve your stamina and other things. Should be avoided. But
Um,
those
Most of
who
the people, one of the study which I have told is even taking a warm water before the exercise is giving an equal weightage as that of a caffeine. Studies have been done for that also. That's why I am
okay.
little bit I'm not telling the clear cut take caffeine because we
Okay.
have
Yeah,
seen
yeah,
a
yeah.
lot of studies.
Excellent,
Okay.
excellent presentation, Dr.
Thank you.
Senthil. Excellent,
Yeah.
excellent.
Thank you, sir. Thank you, sir.
Thanks.
Thank you.